Good morning, everyone. If you're just joining us now, we'll be starting in just about 3 or 4 minutes. So please grab your last cup of coffee, make yourself comfortable, and mute your phones or mute the computer audio so that we'll be able to hear the speaker. We'll be starting shortly. Thank you. Okay, I think we'll get started. Welcome to today's webinar entitled The Role of Antibiotic Allergies in Antimicrobial Stewardship in Long-Term Care Facilities. My name is Barbara Zarowitz. I'm a faculty member here at the Peter Lamy Center at the University of Maryland School of Pharmacy. And it's my pleasure to bring you a new topic today. We've moved through antibiograms and really wanted to focus in on another area related to antibiotic potential for misuse and overuse in some cases. Today, I'm really delighted to have speaking Dr. Emily Heil, who is an assistant professor in the Department of Pharmacy Practice and Science at the University of Maryland School of Pharmacy. She also serves as the pharmacy director of the Antimicrobial Stewardship Program at the University of Maryland Medical Center. Emily completed her undergraduate and doctor of pharmacy degrees at the University of North Carolina in Chapel Hill, and subsequently completed her pharmacy practice and infectious disease training at the University of North Carolina hospitals. She is currently serving as the secretary of the National Association called Society of Infectious Diseases Pharmacists. Her research interests include individualization of antimicrobial dosing, particularly in critically ill patients, antibiotic allergies, gram-negative resistance, and antimicrobial stewardship. It's my pleasure to turn the program over to Dr. Heil. Emily?
Thank you, Barbara. I appreciate the kind introduction, and thanks everyone for joining me during your lunch hour today. So our objectives for today's presentation are going to be to understand the potential harms of penicillin allergy labels and how that relates to our goals with antimicrobial stewardship. We're going to introduce strategies to optimize the treatment of penicillin allergic patients as an antimicrobial stewardship initiative and describe different processes that we can use within our facilities to delabel patients of a penicillin allergy. So to start, beta-lactams are the most commonly used, and I would argue the most important antibiotic group that we have in the United States. Their core structure is a beta-lactam ring, which you can see here in the middle of each of these groups of antibiotics, and they have variable side chains at the R site. It's these side chains that provide the variation in their spectrum of activity, their duration of action, and also what contributes to the cross-reactivity potential in the setting of a penicillin allergy. There are 4 types of drug-related allergies. Type 1 reactions are mediated by IgE, and symptoms are related to the activation of mast cells and basophils after drug exposure. Often, patients who develop type 1 reactions have had prior drug exposure or sensitization, but lack of prior drug exposure does not preclude the presence of a type 1 reaction. Symptoms of type 1 reaction include urticaria, angioedema, bronchospasm, shortness of breath, and of course, the most concerning, anaphylaxis. Urticaria is the most severe and most common and least severe symptom of type 1 reactions, and it's characterized by a wheal or flare reaction and the rapid development of irregular, pruritic, blanched papules on erythematous bases. Wheals can range from pinpoint to several centimeters in diameter and can have an appearance similar to that of a mosquito or insect bite. Angioedema is characterized by swelling of the face, extremities, and airways that may lead to respiratory compromise by bronchospasm or asphyxia. And then anaphylaxis, of course, the most serious type 1 reaction, is characterized by the rapid onset over minutes to hours of symptoms that may include urticaria, but also life-threatening symptoms such as respiratory compromise or hypotension. Type 1 reactions typically occur within minutes to hours of exposure to the drug, but may occur up to 72 hours afterwards. A reaction that occurs greater than 72 hours after drug exposure could still be mediated by IgE, but it's more likely to be one of the delayed type reactions and not a type 1 reaction. It's important to note that we only provide penicillin skin testing or desensitization for type 1 allergies. Other allergies should never be rechallenged. Type 2 allergic reactions are cytotoxic reactions such as penicillin-induced hemolytic anemia. Type 3 allergic reactions are immune complex reactions such as serum sickness. And type 4 reactions are cell-mediated reactions such as contact dermatitis. There are also immune complex mediated reactions such as Stevens-Johnson syndrome and toxic epidermal necrolysis, neither of which should ever be rechallenged for a patient. So the reason penicillin allergies are such a hot topic is that penicillins and other beta-lactams represent the most frequent cause of medication-induced anaphylaxis. And up to 10% of the population reports a penicillin allergy, with few of these reports actually reflecting true serious allergic risk and often reflecting historical child events, family history, or non-allergic adverse events such as GI upset. To get an idea of the scope of reported penicillin allergies, a quick data poll revealed that over 6,200 patients admitted to our hospital over a 2-year time period reported a penicillin allergy. Additionally, rates of reported penicillin allergy tend to be higher in our older patients, likely due to decreased use of good old-fashioned penicillin over time. So the frequent reporting of penicillin allergies is likely overstated. Even with a well-documented allergy, hypersensitivity may not persist over time. People can lose up to 80% of their anti-penicillin IgE antibodies over a 10-year period. So even a real allergic reaction experienced as a child may no longer be relevant in adulthood. A commonly cited number in the literature is that 9 out of 10 patients who claim to be allergic to penicillin are found to not be truly allergic when assessed by penicillin skin testing. Probably one of the most unfortunate and concerning statistics is that preferred beta-lactam therapy is avoided in greater than 50% of patients who report a penicillin allergy, even when the documented prior reaction is not severe. And why does this matter so much? It's because the beta-lactam agents, specifically penicillins and cephalosporins, are the treatments of choice against many pathogens that cause common diseases. Examples of these include surgical prophylaxis, where the beta-lactams, particularly cefazolin, is recommended for many surgical procedures. Methicillin-sensitive Staph aureus bacteremia, beta-lactams have been shown to be superior to vancomycin in terms of clinical outcomes. Additionally, broad-spectrum beta-lactams such as piperacillin tazobactam or cefepime are the mainstays of treatment for severe pseudomonal infections in hospital facilities. Penicillin also remains the drug of choice for group A streptococcal infections and syphilis. So for all of these reasons, we want to make sure patients are able to receive these drugs whenever they have one of these indications. Unfortunately, beta-lactam alternatives are often prescribed in long-term care facilities, particularly when a penicillin allergy is reported. Surveillance data from all long-term care facilities in Ontario found that fluoroquinolones were the most common class of antibiotics prescribed overall. This is important because in general we know that the beta-lactams are the safer treatment options for our older patients. Fluoroquinolones come with a host of side effects and multiple black box warnings, including the potential for QT prolongation, tendinitis and tendon rupture, derangements in blood glucose management, and CNS toxicities including insomnia and hallucinations, which can be particularly problematic and are more common in our elderly patients. The fluoroquinolones are often also associated with more drug-drug interactions than a lot of the beta-lactam agents. Other non-beta-lactam options like the macrolides are also associated with QT prolongation and drug-drug interaction potential. And then finally, sulfamethoxazole trimethoprim, or Bactrim, Septra, whichever brand name you like to refer to it as, is also associated with drug-drug interactions, the potential for hyperkalemia, renal dysfunction, and overall decreased tolerance in an elderly population. A major goal of antimicrobial stewardship is to minimize antibiotic-associated adverse effects. So avoiding these drug classes and substituting safer, often first-line beta-lactam agents is a really important goal of antimicrobial stewardship programs. The reporting of a penicillin allergy is by no means benign. Patients who report a penicillin allergy are more likely to experience antibiotic-associated adverse effects, experience longer hospital stays, and more hospital readmissions that are associated with $65 million in healthcare expenditures a year. In a study specifically focusing on older patients that reported a penicillin allergy, they found that the patients reporting a penicillin allergy had an on average 2-day longer length of stay and a discharge status that was less often to home. Patients with reported penicillin allergy have an increased risk for developing multi-drug resistant infections, including 14% more MRSA, 30% more VRE, and nearly a quarter more C. difficile infections than patients not reporting a penicillin allergy. Additionally, patients have a 50% increased odds of surgical site infection due to receiving secondary surgical prophylaxis agents. And as you might expect, patients who report a penicillin allergy have increased utilization of broad-spectrum antibiotics, including clindamycin and vancomycin, and most importantly, because of their toxicities in our older patients, they get more fluoroquinolones. So based on that list, you can also guess that's why most of these patients experience more C. diff and antibiotic-associated adverse events such as nephrotoxicity compared to patients who don't report an allergy. Antibiotic costs are 63% higher in patients reporting a penicillin allergy than those not. And finally, antibiotic regimens deviate from the gold standard in almost half of patients with a reported antibiotic allergy. Unfortunately, having a good antibiotic history in the chart to help determine if a patient is truly allergic or might be able to safely receive an alternative beta-lactam is rare. Overall, allergy history documentation is poor and frequently lacks the nature and severity of the reaction. One retrospective cohort study of allergy documentation at an academic medical center found that only 39.8% of records had a specific allergen identified, and only 22.7% had their reactions characterized. Improvement of allergy history documentation can help us to identify patients who had mild versus life-threatening reactions and identify situations where a re-challenge with a beta-lactam is more likely. Also, as you may have noted in your own practices, patients who report a penicillin allergy often receive a penicillin or penicillin-related antibiotic anyway. This can be for a number of reasons. Perhaps it accidentally slipped through the cracks of all of our electronic medical alerts, or perhaps a reaction was noted to be mild during patient interview, but never documented in the chart. In these scenarios, the allergy records are rarely updated to document patient tolerance of the penicillin. We did a small quality improvement project at our hospital where we identified all patients who reported a penicillin allergy and received a penicillin or penicillin-like antibiotic, such as ampicillin, amoxicillin, piperacillin tazobactam, or ampicillin sulbactam during their hospital stay. Only 18% of those patients had their allergy history updated to reflect that they tolerated this penicillin-like antibiotic. Similarly, allergy history records are rarely updated to indicate tolerance of other beta-lactams, such as cephalosporins. This perpetuates the cycle of patients receiving non-beta-lactam alternative agents during subsequent admission or healthcare visits. Utilization of algorithms or electronic medical record prompts can help us improve the quality of our allergy history documentation. One of the most important things we can do is to conduct a thorough allergy history with our patients. Some questions that we should always be asking our patients include what was the name of the medication they were allergic to, how long ago did the reaction occur, because as we talked about earlier, patients can actually lose that those IgE antibodies over time. So if it was a childhood reaction and the patient's now in their 60s or 70s, that might increase the likelihood that the allergy is no longer significant. What systems were involved in the reaction and what were the characteristics of the reaction? When during the course did the reaction occur? So was it within an hour of the first dose, or was it 4 weeks into therapy, making it more likely to be something like a type 4 mediated reaction? Why was the medication prescribed in the first place? Was the patient taking concurrent medications at the time of reaction? Translation, were there other things that could maybe have been contributing to what happened? One of the most important questions, I think, is what was the therapeutic management required secondary to the reaction? Patients who had a true anaphylactoid reaction to penicillin rarely forget needing to seek medical attention. However, if they say, well, I don't exactly remember what happened, it's less likely that they experienced a life-threatening reaction. Has the patient taken the same or other cross-reacting medications before or since the reaction? It's important to list out common brand and generic names of these medications to patients to help jog their memory. We often run into patients that swear they've had a penicillin allergy, but asked if they've ever taken something like Augmentin, they say, oh yeah, I've taken that. And then has the patient been exposed to the same or similar medication since the reaction? Finally, other questions can be asked to determine if the patient might have any conditions that predispose them to allergies or other similar symptoms that may not have actually been related to the drug. So the following two slides depict the algorithm we use to guide our nursing and providers in allergy history documentation. It's by no means a perfect algorithm, but just an example of a way to ensure that pertinent points about the patient's allergy history are being documented. An initial objective of the history is to classify the reaction and what it was and when it occurred. And then our subsequent questions follow up on the severity of the reaction, specifically whether or not the patient went to the hospital or required an ICU admission. For patients that report things such as nausea, vomiting, diarrhea, things that tend to be more adverse effects than actual allergies, we recommend delabeling the patient of the penicillin allergy. When patients do report previous signs and symptoms of angioedema or anaphylaxis, those are patients that we can confidently label as severely penicillin allergic. But for all patients, it's also important to also ask if they've taken other beta-lactams in the past without reaction, and to document which ones they have, if so. Unfortunately, even after a systemic evaluation, some patients may still not be able to recall the nature of the reaction, so the reaction has to be classified as unknown. These are situations where penicillin skin testing, which we'll talk about later in the presentation, can be particularly useful. Patients reporting a rash require a little bit further exploration. If the antibiotic caused a rash, inquiring about the nature of the rash is important. Key queries about a rash include the location, classified as local, perhaps it was just on a portion of their arm or their leg, or generalized where it covered more of their body. Extent, classified as the estimated proportion of the body surface area involved, and whether or not mucous membranes were involved. And description of the rash. Was it raised, flat, blistering, pustular, pruritic, non-pruritic? Patients should also be asked about systemic symptoms at the time of the rash, including fever, any respiratory symptoms, edema, particularly of the hands and face. Characteristics that would suggest a type 1 or IgE-mediated reaction include the presence of a pruritic raised rash that appears similar to mosquito bites. Urticaria is extremely pruritic, so if a rash is not pruritic, it's almost certainly not urticaria. Additionally, timing of onset of the drug is most important, as we know most of these type 1 reactions occur within 1 hour of taking the drug. Most electronic records provide many fields in which to document a patient's allergy history. This can be an important area for staff education on how to optimally fill out the record. Just as an example, we created a best practice advisory, which is an alert that fires when only 2 out of the 5 boxes for the penicillin allergy history are filled out. And the alert says that inadequate documentation of penicillin allergies can lead to suboptimal antibiotic therapy, and encourage the practitioner to go back and do better documentation of the fields with an example screenshot listed. So leveraging your electronic medical record, if you have access to one at your facility, is a good way to potentially improve allergy history documentation. Additionally, pharmacists are well positioned to help clarify allergy histories. This was a study that aimed to test the impact of a pharmacy-led beta-lactam allergy interview on the duration of fluoroquinolones at a small community hospital. It was a quasi-experimental design with a prospective cohort and a historical control group that was used to assess patients with a reported penicillin allergy. The primary outcome was duration of fluoroquinolones before and after implementation of this interview process. Secondary outcomes included length of stay, percentage of patients switched to a beta-lactam antibiotic, and discrepancies between allergies in the medical records and what was reported in the interview. A total of 80 patients were included in the study, with 43 in the control group and 37 in the prospective group. Fluoroquinolone duration was reduced after the implementation of the pharmacist-led beta-lactam allergy interview. And in all, 49% of patients in the prospective group were switched to a beta-lactam alternative agent after conducting the interview, with no reported allergic reactions, adverse effects, or impact on length of stay. So this study reinforces that just investing in allergy history taking alone may represent a safe and effective first step in optimizing allergy management and avoiding use of fluoroquinolones in our patients. When it comes to penicillins and cross-reactivity with other beta-lactam agents, the primary driver is related to side chains. For the first-generation cephalosporins, the risk of cross-reactivity is higher, and while previously documented in the literature to be as high as 10%, Newer reports suggest that it's actually less than 5%. Risk of cross-reactivity related to the later generation cephalosporins is really negligible. For carbapenems, early studies noted cross-reactivity of up to 50%. However, more recent data indicates rates are actually lower than 10%. So given these overall low rates of cross-reactivity, an important step for stewardship programs is to assess whether cephalosporin alternatives are used in situations where patients have a history of only a mild penicillin allergy without immediately turning to non-beta-lactam alternatives, which is why that accurate allergy history from the previous slides is so important. In a study of patients with a true history of anaphylaxis to penicillin, cross-reactivity with cephalosporins was nearly 40%, but this was almost exclusively associated with cephalosporins with shared chemical side chains to penicillin. This table is meant to serve as a reference of beta-lactam antibiotics that share identical side chains at the R1 site. Each column represents a group of antibiotics with identical R1 side chains. Beta-lactams with similar side chains deserve a cautious approach. For example, it would be appropriate to avoid using cephalexin in a patient with an amoxicillin allergy due to their shared side chain. So even with improved documentation and increasing comfort with challenging patients with other beta-lactams, such as cephalosporins, there will still be many situations where a patient's allergy history might be unclear, particularly in an older patient who may not be able to provide a history themselves or whose family members might not know the details of the previous reactions. There are a few options available to address allergies when the picture is less clear, so we'll touch on each of these briefly in the coming slides. So desensitizations are a way to induce temporary tolerance of a beta-lactam agent, but these do require an inpatient admission and close nursing supervision, making them impractical for a long-term care setting. The preparation of a beta-lactam desensitization is quite time-consuming for pharmacy, with multiple tedious serial dilutions that must be prepared. Additionally, patients should be in an ICU setting with close monitoring, ideally one-to-one nursing throughout the procedure. Exquisite compliance with antibiotic administration times is essential after the desensitization, as the whole process must be repeated if more than one half-life elapses between doses. And finally, the effects are not sustained and only good during that treatment course. So while a desensitization imparts temporary tolerance for that drug, it doesn't actually tell you anything about whether or not the patient had a true allergy to begin with. So it makes much more sense to use some of the strategies to rule out the allergy. A graded challenge is cautiously administering a medication to a patient who is unlikely to be allergic to it. It's not the same as the desensitization because it does not entail modification of the immune response or induce tolerance to the drug. But since it involves using lower doses of the antibiotic being given initially, the thought is that if an allergic reaction happens, hopefully it will be minor and easily treated. If patients are on beta blockers, they should have those discontinued prior to the graded challenge to prevent treatment-resistant anaphylaxis if it occurs. Graded challenges are usually given in 3 to 5 steps, such as 1% of the dose, followed by 10% of the dose at 30-minute intervals, and then if tolerated, proceeding to the full therapeutic dose. Patients should be monitored for symptoms of an allergic reaction between each concentration change with vitals at baseline and prior to each drug administration. These can be used cautiously in patients where the allergy history is unclear, but based on the time of onset, or if greater than 10 years ago, or potentially if looking to evaluate tolerance of a different beta-lactam than what the patient reported their initial allergy to, can be quite helpful. However, this is also something that should be done in an inpatient setting, making it less practical for long-term care. There's been growing interest in the role of direct oral challenges in patients with low-risk penicillin allergy histories to help address the obstacles that prevent widespread access to formal penicillin allergy skin testing programs. Direct oral challenges involve administering a 250 milligram dose of amoxicillin by mouth and observing the patient for 1 hour post-dose. This is reserved for patients with a low suspicion of drug anaphylactic allergy, such as a history of benign childhood rash, a history of non-urticarial rash, adverse drug events such as nausea or vomiting, or patients with a distant history of an unknown reaction. This is something that can be done and is done in the outpatient setting or in long-term care facility settings, as long as appropriate patient monitoring is available with access to emergency resources. This process is overall really safe in patients that are at low risk of serious allergic reactions. In a study of direct drug challenges performed by allergists in ambulatory clinics, only 1.5% of 402 healthy young military recruits with penicillin allergy proved to have a true penicillin allergy upon oral challenge. In another study, 155 outpatients with reported penicillin allergy were given the oral challenge, and 2.6% were found to be allergic to penicillin and developed minor rashes after the direct oral challenge. The Antimicrobial Stewardship Guidelines that were updated in 2016 recommend penicillin skin testing now. The guidelines state that in patients with a history of beta-lactam allergy, stewardship programs should promote allergy assessments and penicillin skin testing when appropriate. Penicillin skin testing, however, remains largely unstudied as a primary stewardship intervention, so unfortunately they gave this recommendation a weak level of evidence, or a weak recommendation with low quality level of evidence. So what is penicillin skin testing? After administration, penicillin breaks down into smaller molecules. These molecules are too small to elicit an allergic reaction on their own, but they can be bound to proteins called haptens, a process called haptenation. This complex of penicillin reactive intermediates and hapten can trigger a reaction in a sensitized patient. The reactive intermediates of penicillin are referred to as the major determinants and minor determinants. The major determinants are formulated in something called benzyl penicillinoyl polylysine, and these represent 90% of all of the intermediates that patients are reactive to, while the minor determinants comprise the remaining 10%. Penicillin skin testing antigens react with IgE antibodies if present at the injection site, resulting in a skin wheal, flare, or bleb. When performed in the appropriate setting with proper technique and reagents, the penicillin skin test has a negative predictive value of 97 to 99%. The positive predictive value is difficult to really know and not truly ethical to study. If you think someone has a penicillin allergy, it's probably not ethical to then give them penicillin to see what happens, but it's estimated to be around 50%. So said another way, patients with a negative penicillin skin test are at no greater risk of experiencing an allergic reaction to a beta-lactam than a patient coming in off the street with no history of an allergy. So who makes a good candidate for penicillin skin testing? Patients that, based on history, that could have had an IgE-mediated allergic reaction are our best candidates for penicillin skin testing. It's best suited for patients where the allergy history is convincing enough that you're not comfortable proceeding with either a direct oral challenge or potentially administering the patient with a cephalosporin. Or if you have a patient with a distant history of a true penicillin allergy, but you want to determine if they still have a clinically significant allergy prior to administering a penicillin, then penicillin skin testing is a good option. We typically reserve this for patients with an indication for a long duration of penicillin, such as MSSA endocarditis or Enterococcus faecalis osteomyelitis, just due to the timing of the test. Patients that are known to be extremely hypersensitive to penicillin, such as patients who have convincing histories of recent anaphylaxis, should not be skin tested. Additionally, histamine is an important positive control in the skin test, so patients must not be receiving any histamine blockers, including H1s and H2s, or other therapy that might attenuate a histamine response within 24 to 48 hours of the test. Testing can be done in an inpatient or outpatient setting. It actually originated in an outpatient setting, but has become more popular in an inpatient setting as well. But it's a safe test that can be done in either situation. The supplies that are needed to conduct the test include duo-tip skin prick devices, a measuring card, the major determinants of penicillin allergy, which is benzyl penicillinoyl polylysine, a diluted version of penicillin G, histamine for your positive control, and normal saline for your negative control. The patient's arm is swabbed using an alcohol swab, and then you mark the sections for each reagent on the patient's arm. So, for example, penicillin G, the benzyl penicillinoyl polylysine, the negative control, and the positive control. A drop of each reagent is placed onto the forearm and punctured at the drop site with a duo-tip device using a slight twisting motion. It's meant to barely break the surface of the skin. We use a new duo-tip for each reagent so as to not cross-contaminate. We wait for about 15 minutes and then observe. What we're looking for is a positive reaction with the positive control. So around where the patient had the drop of histamine, it should look like they have a nice little itchy bug bite. If either the penicillin G or the benzyl penicillin polylysine also has a greater than 3 millimeter wheal in diameter compared to the negative control, which is the normal saline, then we would consider this a positive test. A negative test would be the absence of a wheal less than 3 millimeters compared to the negative control. An equivocal test is when it's less than 3 millimeters with little or no erythema and no itching. And then finally, an invalid test is when the positive control does not react. So that means that your histamine did not create the little bug bite, and you need to potentially repeat the test. So if the test is positive at this point, we don't advance to the next part, which is the intradermal test. We would consider the patient to be pen allergic at this point and not move any further. If it's equivocal or negative, we move on to the next step, which is the intradermal part of the testing. So the intradermal testing involves using a tuberculin syringe where you inject a little bleb of the penicillin, the major determinants, which is the benzyl penicillin polylysine, a bleb of the diluted penicillin G, and a bleb of the normal saline. You no longer use the histamine for this part of the test. You create 3 small blebs on the forearm for each agent, and then you draw tight circles around the blebs and wait 15 minutes to observe. The same interpretation is used as for the skin test prick. So here's just an example of a very positive test where you can see relative to the control agent that the blebs for the penicillin G and the benzyl penicillin polylysine have increased greater than 3 millimeters beyond the initial bleb. So this patient would be considered allergic. After skin testing, it's really important to educate the patient about their test results so that the allergy doesn't just get re-added to the chart when the patient next encounters the healthcare system. A lot of patients have carried that penicillin allergy label with them for so long that it's easy for them when they're asked if they have an allergy at a hospital visit, an ED visit, an urgent care visit, or just a primary care visit to say, oh yes, I do have a penicillin allergy. So it's really important to go over with the patient what the testing was for, what it means, and how they can confidently say that they are not penicillin allergic when they talk to their healthcare providers during the next interactions. So we provide an educational handout to our patients along with a little 2-sided pocket card for the patients to keep in their wallet that we tell them to provide to any healthcare providers that they come into contact with to make sure that this information is shared. So at our hospital, we have infectious diseases fellows leading this penicillin skin testing, which works well for us since they are often the ones making the subsequent antibiotic recommendations. But there's so many other models for penicillin skin testing depending on your own resources. So as this is obviously their wheelhouse, having allergists perform the testing is the ideal situation when available. But many institutions do not have access to inpatient allergy consultants. And depending on the indication for antibiotics, it would not always be practical to refer patients for an outpatient allergy visit. Pharmacists run and manage programs are great options for states that allow pharmacists to place the test. Other physician specialties, such as emergency medicine physicians and hospitalists, have demonstrated successful penicillin skin testing models. The outpatient setting is actually where reimbursement for the testing is best if an acute test isn't needed to drive a change in antibiotic therapy. And testing in a preoperative setting can be beneficial to improve optimal surgical prophylaxis in patients about to undergo a surgical procedure. Preemptive testing in the outpatient setting, where a patient is tested even if they don't have an acute antibiotic need, to rule out the allergy can also be very beneficial. It's good to just have the patient tested, wipe their allergy record clean of that penicillin allergy history, so that way if they do have subsequent antibiotic needs down the road, this won't be a barrier. This is something that we've done preemptively in patients that are at high risk or immunocompromised and are likely to need antibiotics in the future, such as some of our hematologic malignancy patients or transplant patients. We'll just have them tested to get that allergy ruled out in the outpatient setting. So after any allergy evaluation, whether it be a good history taking, a direct oral challenge, or a penicillin skin test, should ultimately lead to the patient's medical record being updated accordingly. And this information should also be communicated to other healthcare providers for the patient, such as their community pharmacy, in the setting that we don't have a shared electronic medical record. It's important that all providers involved in this patient's care are able to know this information. We often will delete the allergy and add quantifying comments such as penicillin skin test negative or tolerated amoxicillin clavulanic acid to help provide further information as to why we're delabeling the patient of that allergy. So this is just a nice table to summarize the different options available for patients based on their allergy history. Patients that, by their history, are considered low risk are patients where their reactions were unlikely to represent actual allergies, such as gastrointestinal symptoms, patients who had itching without a rash, or a remote unknown reaction, or patients who mistakenly report a penicillin allergy family history, but no direct known allergy to themselves. These are patients that make great candidates for a direct oral challenge with amoxicillin. Patients that are considered medium risk would be patients with urticaria or other pruritic rashes, or reactions with features of IgE-mediated allergies such as itching and flushing, but no actual anaphylaxis. These are patients that make great candidates for penicillin skin testing, followed by an amoxicillin oral challenge if the skin test is negative. And then finally, patients that have a convincing allergy history with anaphylactic symptoms, recurrent reactions, or reactions to multiple beta-lactam drugs probably merit an allergy referral to really let the experts suss out the situation. This is a review article that just came out a couple of months ago that provides a really fantastic overview of everything we've just talked about, and also has 2 supplements that provide templates for allergy history taking, a protocol for direct oral challenges, and a reference chart for cross-reactivity, all of which you can use and implement within your own institution. So it's a really great resource that I would recommend everybody take a peek at. So while the main focus on this presentation was penicillin, I did want to briefly touch on sulfonamide allergies, particularly as it relates to cross-reactivity. Sulfamethoxazole is the second most commonly reported antibiotic allergy behind penicillin. Sulfonamides in general run the gamut from sumatriptan to furosemide to the antibiotic sulfamethoxazole. So one thing that pharmacists frequently get asked is an allergy to one really a contraindication to the rest of them? So a sulfonamide is any drug containing the sulfonamide moiety, which is highlighted in yellow on this slide. But there are 2 other critically important groups to note: a primary N4 arlamine in blue and an N1 heterocyclic ring in red. Type 1 IgE-mediated allergic reactions for Bactrim come from the heterocyclic ring at the N1 position. This was determined by taking sera from patients with anaphylaxis to sulfamethoxazole and performing inhibition assays to culprit IgEs with sulfonamide. Sulfamethoxazole and other related antibiotics are the only sulfonamide drugs that have this N1 heterocyclic rings. Other sulfonamides, such as furosemide, lack it, and therefore any potential for type 1 allergy cross-reactivity. The non-type 1 hypersensitivities are more of a concern with sulfamethoxazole, and these include some of the dermatiopathies like Stevens-Johnson syndrome or DRESS. These reactions are mediated by IgE and IgM complexes, or T cells, and it's not the parent sulfamethoxazole, but downstream metabolites that are necessary for this reaction to occur. So for Bactrim reactions, it's really not about the sulfonamide moiety at all, but the 2 functional groups attached instead. So what data do we have for using sulfonamide non-antibiotics in patients with reported sulfonamide allergy? A big New England Journal of Medicine study in 2003 looked at a group of UK outpatients with and without sulfa allergies. Those with the allergy were more likely than those without the allergy to react to a sulfa non-antibiotic. However, they were even more likely to react to a penicillin antibiotic than those with penicillin allergy histories. So this indicates that it's likely, as the authors put it, a general predisposition to having an allergic reaction among certain patients, rather than a specific cross-reactivity with drugs containing the sulfonamide moiety. The next time you're faced with a patient that needs diuresis but has a sulfa allergy in the chart, feel free to load them up with furosemide. You don't need to turn to ethacrynic acid. So to wrap up, 50 to 80% of older adults in long-term care facilities receive at least 1 antibiotic course per year, and the prevalence of reported penicillin allergy increases with age. We know that our older adults are more vulnerable to suffering from antibiotic adverse effects associated with the use of non-beta-lactam alternative antibiotics, particularly the fluoroquinolones. So penicillin allergy evaluations could have significant benefits for older adults in long-term care facility settings. So I appreciate your time and attention today. You will be receiving, following this webinar, an activity evaluation that you must fill out to receive your 1 hour of CE credit. So at this point, I'd be happy to take any questions if there are any. And I would also like to remind people about our upcoming faculty office hours. If you don't have any questions at this point, but you think of something in the next week or two, I'll be available on a webinar on Wednesday, April 17th from 1 to 2 p.m., where you can submit questions ahead of time or log on and ask me live for any questions you have about antibiotic allergies and related questions and how this might relate to your stewardship program. So at this time, please feel free to type your questions in the chat box at the bottom of your screen, or if you want to ask a question over audio, you can unmute your microphones at this time.
Dr. Heil, as participants are perhaps formulating their questions, I'd like to, first of all, thank you for a very excellent presentation. I would also like to remind everyone, as you did, that the continuing nursing education credit comes after completion of the evaluation form, and then the participants must request credit via email through the University of Maryland School of Pharmacy, and it should get their certificates about 2 weeks later. But don't wait to do that, because the activity CE is only active for 30 days after this presentation. For pharmacists, you can simply complete the evaluation, and it's performed electronically thereafter. So with that, again, if you want to exit full screen and use the chat box on the right side to ask any questions, we'd be happy to take them, and or pick up your telephone, or open your audio on your microphone computer. Questions? So Emily, this is the question I have. What percentage, in your estimation, of antibiotic therapy is inappropriate on the basis of suspected but mislabeled allergy? Do you have those data for long-term care?
I actually don't know of any data specific to long-term care for this question, so it would be an interesting study that our group could do, but I can at least speak to the hospital side, where you can attribute a solid percentage of inappropriate utilization to allergies, especially in the setting of surgical prophylaxis. That's an area that's been really well defined, that surgical site infections are actually highly attributable to receipt of secondary prophylaxis due to penicillin allergy. So most of the data comes from looking at the patients that report allergy and then whether or not they receive appropriate therapy, and not in the reverse direction, as you mentioned. But at least anecdotally, I can assure that I feel like the vast majority of our use of fluoroquinolones and alternate agents is really driven by allergy history alone.
Thank you. I have another question, sort of more from the practical standpoint. I'm at the bedside, and I may be the nurse or the aide evaluating a resident in the nursing home. We know that antibiotics are being started this morning. We don't know exactly when. So without any history of allergy, just as a general rule, what is the frequency and the timeline that you recommend monitoring patients, like going back in, evaluating them, assessing whether they may or may not be having an allergic response to the antibiotic? And then secondly, if we know we have an allergy history and it's not clear that it was significant, so not IgE mediated, how would that change your monitoring frequency?
Those are good questions. So actual true anaphylaxis to penicillin is actually exceedingly rare, and less than 0.2% of the whole population has that level of severity of reaction. So that is one reassuring statistic that we can all have in mind. But in general, the vast majority of anaphylactoid type reactions to antibiotics are going to occur within an hour of administration, which is why we only do an hour of monitoring for patients after providing them with something like a direct oral challenge, because that hour is adequate to catch the vast majority of reactions if they're going to occur. So certainly you can have reactions that occur later in the patient's course, but the vast majority of your IgE-mediated reactions really do happen within a 1 hour time period. Now, something like a type 4 delayed reaction, that's something that can be common with drugs like cefazolin, where patients have been on the drug for a couple of days and then they develop a mild rash. That's something that is not usually, it's not going to develop into like a life-threatening reaction. And so as long as the patient is comfortable and can tolerate having the rash, you might potentially treat through if there's no alternative agent. But some of those other non-type 1 mediated allergies like type 2 and type 3, like serum sickness, or the immune complex reactions like Stevens-Johnson syndrome, you would never want to re-challenge a patient in those situations because those reactions can potentially be fatal, and it's not something that the patient would develop a tolerance to, and you also have increased risk upon re-exposure to the original agent. So in terms of close, like one-to-one nursing monitoring or checking back in on that patient after they're receiving an antibiotic for the first time, it's really within that initial 1 hour window that you want to be keeping a closer eye on the patient before you can sort of breathe your sigh of relief and proceed normally, because those other reactions that are less common are not going to be as quick.
So as you can see from the chat box, one of the participants is asking us to clarify, and would it be different if it was an orally administered antibiotic as opposed to an IV?
That's a good question, since the onset in terms of like time to peak levels and stuff can be slightly different between an oral and an IV antibiotic, but you would still expect the reaction to be within the first hour if it's going to happen, because even with a lot of your oral beta-lactams, your time to peak blood level concentrations is only around 30 minutes, so it's not that much more delayed than what we get with IV antibiotics.
And as another, thank you, Emily, as another follow-up question, let's assume it was a delayed reaction with and a rash with urticaria that the physician or prescriber chose to treat through. What, as a nurse or as an aide, what could we apply or do to help the patient tolerate the urticaria so as to not have to abandon the course of antibiotics for an alternative? Are there medications or topicals that have been shown to be helpful?
Yeah, these are heavily histamine-mediated reactions, so any of your antihistamine products like diphenhydramine would be options for the patients. I mean, we do worry about the anticholinergic side effects in our older patients, but lower doses, just as tolerated as needed, would be appropriate in that case.
Would topical work?
I think topical might provide some symptomatic relief if they are having a mild rash, but the systemic agents tend to be more impactful.
Okay, thank you. I'm not trying to preoccupy her with all the questions, ladies and gentlemen. Are there others coming from the participants? Emily, I'm seeing no other questions. Unless there are any participants on the line that would like to talk about how they're handling allergy monitoring and implementing responses to potential allergies at their facilities. We'd love to hear. Okay, I guess I can't be Dr. Brandt and put everyone on the spot by name today. So with that, Emily, did you have anything else to add?
I have nothing further to add. If you think of any questions, feel free to join us for our faculty hours on office hours on the 17th.
Yes, everyone, thank you so much for your attendance, and we appreciate your ongoing passion for improving the quality of antibiotic use and antibiotic stewardship in long-term care. Have a wonderful rest of your day.